Hello everyone, my name is Teresa Martinez and I am going to present my musculoskeletal SOAP note for this week. My patient's name, or initials, are YJ. Date of birth is 9/16/2016 and is 9 years old. He's accompanied by his mother and himself, both reliable historians. His chief complaint is my ankle hurts from soccer, and then she said he bruises easily. HPI includes a 9-year-old male who presents with his mother for evaluation of a right ankle injury sustained 48 hours prior during a soccer match. He describes feeling a pop and an immediate lateral ankle pain. He was unable to return to play and required assistance off the field. Initial management included rest and ice from his parents. He reports progressive lateral ankle swelling and the development of significant bruising that appeared within 6 hours of injury. The pain is localized to the lateral ankle, sharp with weight bearing, and he rates it as a 7 out of 10 on the pain scale. He also notes a secondary milder 3 out of 10 pain in his right little toe, which he struck on the ground during the fall. He is ambulating with a pronounced limp. Critically, the history also reveals a broader concern. The mother reports a long-standing pattern of spontaneous ecchymosis on the patient's shins and forearms, often appearing without any trauma. She states he's always bruised more easily than his siblings, describing him as a boy who was always covered in bruises. She denies any history of prolonged bleeding from minor cuts, gum bleeding, or gum bleeding or nose bleeding, and there is no recent history of fever, weight loss, or fatigue. Medication-wise, he's not taking any medications. There are no known drug allergies, environmental or food allergies. Past medical history does include a full-term birth with no significant illness or hospitalizations. Family history, the mother does have a history of iron deficiency anemia, no known bleeding or rheumatologic disorders. Social history, he's a 4th grade student. He is active in soccer and baseball. He lives with both parents and one brother, and development is appropriate for his age. Review of systems, constitutional. He denies any fever, chills, or weight loss, but does report mild fatigue since the injury. He attributes this to pain and disrupted sleep. Musculoskeletal-wise, he reports right lateral ankle pain and right toe pain. He denies any history of joint swelling, muscle aches, or other joint pains. For head, ears, eyes, and nose, for eyes, he denies any visual changes, floaters, or history of retinal hemorrhages. He denies any nosebleeds, gum bleeding when he brushes or flosses. And then the mother does confirm there's no history of tonsillectomy. Cardiovascular-wise, denies palpitations, chest pain, or shortness of breath. Psychiatric, he does report anxiety about ankle injury and missing his soccer games. GI, he denies any abdominal pain, nausea, vomiting, or diarrhea, and denies any black tarry stools or bright red blood in stool. GU, he denies any blood in urine, dysuria, or unusual frequency. And then hematologic, he does report bruising easily, but denies any lymph node swelling or blood transfusions or any known anemia. His weight is 51 pounds. He is 50 inches tall. Temperature is 98.6. Blood pressure is 108/62. Pulse is 92. Respirations are 20. BMI is 16.5, and he falls under the 50th percentile, which is normal, healthy for the patient. General appearance, he's well groomed, he's well nourished, he's not in any apparent distress. He is seated, he is holding his right foot off the floor, and he does exhibit an antalgic gait when he's asked to walk. Let's see. Integumentary right ankle foot, there is significant localized edema, and ecchymosis over the right lateral malleolus, extending along the lateral dorsum of the foot. His skin is intact and it's warm to the touch. Extremities, he has a multiple well-healed ecchymosis of varying colors, which include yellow, purple, and green. They're noted on bilateral shins and dorsal aspects of both forearms, and they're consistent with the reported spontaneous ecchymosis. Cardiovascular-wise, S1 and S2 are present. There are no murmurs. Respiratory-wise, his lungs are clear. And then musculoskeletal, right lower leg, there's swelling but no visible deformities. The right ankle, there's tenderness over the anterior talofibular ligament. And more distinctly, the calcaneofibular ligament. There's no tenderness over the medial malleolus, fibular head, and the base of the fifth metatarsal. Range of motion of the right ankle is active. Plantar flexion 25 degrees is painful. Dorsiflexion 5 degrees is painful. And then inversion 0 degrees, severely painful. And then passive guarding and pain with all motions, especially when during inversion. And then on his toes, there's mild tenderness to palpation on the fifth right toe. There's no crepitus or deformity. And then he does have pain on the right toe. Neurovascular wise, dorsalis pedis and posterior tibial pulses are 2+. Capillary refill is less than 2 seconds, and then sensation is intact to light touch throughout. We did do the special test of anterior drawer tests, which are negative for significant laxity. We did do a Taylor tilt test, which is positive for pain and mild endpoint laxity compared to the contralateral ankle. And this is highly specific for the calcaneofibular ligament, or the a CFL sprain. So for the assessment, the differential diagnosis, we did say there's a distal fibula fracture. This was selected due to the inversion mechanism, immediate pain and swelling, and then inability to bear weight and the antalgic gait reported by the patient, and also the HPI when we assessed him. This aligns with high-risk features per the clinical decision rules, but it's also ruled out preliminary by absence of bony tenderness or on palpation over the fibula and negative squeeze test, though we do need imaging to exclude it. And then this differential is prioritized as it could alter acute management, which could include the cast or a boot. The next differential diagnosis could be idiopathic thrombocytopenic purpura, and this is selected on the history of spontaneous ecchymosis on the shin and arms without recalled trauma and the easy bruising pattern in a healthy appearing child. Also, the absence of other bleeding symptoms, like he doesn't have any nose bleeding. Idiopathic thrombocytic purpura is a top priority and is the most common cause of isolated bruising in pediatrics. It's not yet ruled out as it's pending labs, for example, like the CBC and platelets. And then we also can choose von Willebrand disease. This is selected due to the chronic history of easy bruising, the spontaneous ecchymosis, and the family history of his mother, which she has anemia, with negative review of systems for severe bleeding. And then this is also prioritized as it's the most common inherited bleeding disorder that fits the mucocutaneous pattern without systemic symptoms. This is also not ruled out as we would need a von Willebrand disease panel if his initial screens are normal. And then the diagnosis is S93.411, which is sprain of calcaneofibular ligament of the right ankle. And then we did write an orthopedic management plan coming up. And then we also can say R23.3, spontaneous ecchymosis. We are going to have to investigate this a little bit more. And then R60.0, the localized edema, which is secondary to his acute injury. And then also M79.674, which is a pain on the right toe, and this is minor secondary diagnosis from the contusion. So this was like a little bit of a difficult case because he did have the sprain, but he also has the hematologic concern of the easy bruising, which involves the musculoskeletal, but also the hematologic and integumentary systems. So for the plan, we are going to need a weight pairing, AP lateral views of the right ankle to rule out a fracture. And then we do want to investigate the ecchymosis, so we do need a CBC with platelet count, PT, INR, and PTT. And then if these are normal, but we still suspect that there could be the von Willebrand, we can do a panel for the factor 8, and then the VWF antigen and VWF activity. For the ankle sprain, the treatment, we want to treat it in different phases. So phase 1, 0 through 1, we want to do the RICE protocol, rest, ice, and compression and elevation. And we want to provide a controlled ankle motion, or CAM, which is a walker boot for protected weight bearing. We also want to tell him to take ibuprofen 10 milligrams per kilogram per dose every 6 to 8 hours. And he wants to take it with food for 5 to 7 days for pain and inflammation. And then for phase 2, which is 1 to 4 weeks, we want to have him go to physical therapy. So refer to physical therapy once his acute pain subsides. We want to focus on him restoring his range of motion, and then strengthening, or perineal strengthening, And then we want to discuss patient education. We want to discuss the diagnosis, the treatment plan, and the importance of physical therapy to prevent chronic instability. And then we also want to educate him on the reason for the hematologic workup. The mother did express that she understood, and she's relieved that we are looking into this. And then we do want him to follow up within 2 weeks to review the x-rays, the lab results, and then reassess the ankle, and we can adjust the plan of care.